Before we go on with our next panel, which is going to be on research on respite outcomes and access, we have a question for you, a poll question, and I'm going to ask it now. Which of the following do you believe policymakers most want to know about respite outcomes? So if you could just answer this. Okay. I think we can close it right now. I don't know why I'm surprised, but I'm a little bit surprised, but cost benefit of 68% suggests that that might be the most interesting, or the what our policymakers are most interested in. I guess I shouldn't have been surprised. So I would like to go to the next slide, please, Marcia. As I said earlier, we're going to have three presenters talking about research on respite outcomes and access to respite. And those are Dr. Rebecca Utz, Joseph Gaugler, Dr. Joseph Gaugler, and Dr. Sarah Sobotka. Their full bios are in the research, the guide to this conference. And right now, I'm going to go ahead and hand this over to Dr. Utz. Thank you.
Okay, thank you. I assume you can all hear me. Somebody nod their head. Yes. Okay, thank you. And whoever's controlling the slides, I will say next as we need to go through. Today, I want to tell you about some of the research that we have been doing here at the University of Utah, which is really focusing on how do caregivers use their respite time? And then based off of some of the research that we've done or that we found, the development of an intervention, which we have now developed and we're beginning to test to see if this notion of the respite time use and time use satisfaction is able to benefit or maximize the benefit of respite for caregivers. So next slide, please. Of course, like any research, this is not work done by me and me alone. And so many of my partners, collaborators, colleagues are listed here. I think some of them are also on the call. So thank you to all of them. This work represents their ideas, their work, their energy, and their effort as well. The other acknowledgement that I'd like to say is that this research is currently funded by the National Institute on Aging through an R01 grant. Next slide, please. So before I begin talking about caregivers and respite, I just want to make sure that the way that I'm defining caregivers and the way I'm talking about respite is the same as what you may be thinking about. So first of all, when I speak of caregivers, I am referring to the informal or family caregivers that are providing care in the home to somebody. These are typically the unpaid family caregivers providing care to somebody disabled, aging, ill, whatever it may be. And respite, I am defining as just simply time away from caregiving, any of the caregiving responsibilities that people have. It's that intentional break that somebody has away from caregiving. And respite, in the way that I'm defining it here, is that respite could be provided by a formal service, such as adult day services or a home health agency or a respite provider coming into the home. But it's also all those informal arrangements that we have where we sort of tag team with other family members or neighbors, those informal arrangements where we have that can also provide a short intentional break for the caregivers. So next slide, please. In our work over the past, I'm going to say even decade and a half, we began looking at what are caregivers doing during these times where they have a break. And what we started to see is that a pretty large portion, almost half of caregivers reported being not all that satisfied with how they're using their respite time. And this type of finding is really problematic for us in the sense that if caregivers aren't happy with using respite, they're saying respite is their most needed and desired service, but they're not all that happy or satisfied with how they're spending it. From a policy perspective, this is really scary because if caregivers are saying this and policymakers getting a hold of that, then we don't have that leverage to get more funding, more support for respite services. So as we dove into this a little bit more about why are caregivers not all that satisfied with their respite time, we began to, next slide please, look at what caregivers are actually doing. So this figure here is probably pretty small as it is coming across on your screen, so I'll walk you through it. We started to look at what kinds of activities are caregivers doing. And you'll see listed there 1 through 19 are the types of activities that we might expect somebody to do, ranging from watching TV and napping to doing housework to doing more of these leisure activities. And these are just some of the types of activities. And what we really thought, and I'll walk you through this here in a moment, is that those activities that are more leisure oriented would be providing more benefit to caregivers than those that are more obligatory, like cleaning and washing the house or cleaning the house. And so what you see here, let me just draw your attention to the red line around housework. What we see here is that caregivers reported both how much time they were spending during respite doing housework, that is their actual time use. So in the case of housework, it was 3.3 hours. But then they also reported what was their desired time use, like how much time do they wish they would have spent in their respite on housework. And so we see that there's a little bit of a difference here. In the case of housework, we see that they're spending more time doing housework than they had wanted to. And so we said, okay, is this also, and then the final column there on this table is just showing you what percentage of respondents in the sample that we used were doing the amount of time they wanted to versus more than they wanted to and less than they wanted to. Draw your attention to the blue line there on an activity like sleeping or napping. And in this case, their actual time use was a little less than an hour, 0.7 of an hour, but they wanted to spend an hour and a half on napping or sleeping during their respite time. So there was a bit of a disconnect about what caregivers wanted to do versus what they were doing during their respite time. So next slide, please. We also began to see comments from caregivers saying things like, I wasted my time watching television. I wish I could have relaxed, but I had to help others and make visits. Or I would like to stay home alone and work on projects that I never have time for. So what these results began to show us in a very descriptive analysis of this time use data, it began to show us that, well, maybe caregivers aren't able to do what they wanted to do during their respite time. So maybe they had time available to them in order to get respite, but they didn't have the ability to do the types of activities that they wanted. And so this work really began to show us that it's not necessarily what types of activities caregivers were doing, but whether they were able to do the amount and type of activities that they planned or wanted to do during respite. And what we did with some of this time use data is that we correlated the amount of activity, the amount of time that caregivers are spending in different activities to see, is it the leisure activities that were causing or that were associated with the greatest benefit of respite? And the answer was no. The key was that they were doing the type of activity that they wanted to do, and they did not feel like they were wasting their time. So, next slide. This led us to the development of an intervention. And in terms of caregiver interventions, there are so many out there that are focused on educating the caregiver, providing skills to caregivers. But we didn't really see any interventions out there specifically about how do we maximize the benefit of respite time use. And so that was the intervention that we started to create. And our goal was to help caregivers get more out of those limited breaks and respite that they did have available to them. And our goal was to focus on this time use variable. And we created an intervention following all the protocols that we should as good researchers, where particularly as good intervention researchers, where we were really focusing on treatment fidelity and making sure that every caregiver got this intervention exactly in the way that any other caregiver would. And what we mean by that is that we had a trained facilitator administer this intervention, focusing on, it basically was goal setting and goal review about their time use. You have respite scheduled next week. What are the types of activities that you would most want to do? And then going through some of the barriers of, well, Why do you think you might not be able to meet a friend for lunch? What would have to happen in order to get there? So the trained facilitator went through this coaching, this goal setting and goal review exercise with the caregivers to show them sort of you can get what you want to get done or what you want to do during your respite time. So next slide. And as we piloted this, here are some of the responses that we got from participants. It worked. And so basically the participants were now saying, if I focus on what I want to do and make sure that during my hour that I have next week or 4 hours, that I do what I want to do, the caregivers were really benefiting. And so we see comments like, I made a greater effort to find fun things to do and actually got around to doing them. Led to other fun things, which I did and will do in the future. It invigorated me. I'm alive and not just living. I love feeling of success when I achieved my goals. I never had time for myself, but since I set my goals, I feel obligated, like a promise I can't cut out. And then I was unconsciously sliding into a resigned death of my own until I started this study. This program really woke me up to the fact that I needn't give up, rather that by setting goals, I can move forward and feel success, even though my circumstances have not changed. I feel like a new, happier person. And so this pilot study and these pilot results, we can also show, it was a fairly small sample, but when caregivers were doing what they wanted to do, that they had planned these types of activities during their respite time, and they were able to succeed in doing those activities during their actual time, they had lower levels of caregiver burden, higher levels of well-being. So the pilot study was working. However, we had a bit of a disconnect here because, as I mentioned, we developed this intervention as any good intervention researcher would, with these trained facilitators to make sure that we had accurate and complete fidelity in how this intervention was being delivered. We came to this conclusion that sending out a trained facilitator 15 to 20 times to a caregiver's house over a course of several months as a coach wasn't feasible. It wasn't possible. Next slide, please. And around the same time that we are doing the pilot, the what do we call this? The expert panel on Respite Research report came out. And that's where we really began to look at our eye towards not just these individual and family and societal outcomes associated with the respite time use, of identifying that. But we also really took to heart this goal of translating our research findings into best practice models. And also maintaining and using these improved research methodologies, but with our eye towards dissemination and translation of this model into practice, we realized that we could not send out trained facilitators or coaches to help caregivers use their time and to plan their respite time. That this needed to be much more cost efficient in order to deliver. And so, based off of some of these research priorities from the ARCH research report, next slide please, we redeveloped this intervention, which is now called Time for Living and Caring, and we designed it in a way that is completely technology delivered. It's essentially now an app that you can get on your phone or on your computer, and it is self-administered. So this now becomes a virtual coach where anybody who has respite that they can use to maximize the benefit of their respite by assessing what are the types of activities they would like to do during respite, and then setting those goals for that type of respite time use. So this now of what we have developed is using strong research methodology, which I will share with you in just a little bit after I describe to you a little bit more about the app we created. But it also has an eye towards using clinical methodology to test the efficacy of this. And we are looking at sort of how to fast track this into best practices and dissemination after efficacy can be established by creating it as a self-administered technology delivered intervention. Next slide, please. So TLC is based off of this pretty simplified theoretical model that I will present to you here, is that the TLC intervention is, if you look at the big white arrow going up top, we want to impact caregiver well-being. And this could be both positive and negative affect, from anxiety and caregiver burden to more positive affect and overall well-being, or the positive aspects of caregiving. We also, within caregiver well-being, we are also focusing on desire to institutionalize, and with the assumption that if we can get greater benefit from respite for the caregivers, we hope that they can also continue providing this care for the care recipients in the home. So the other thing that we have added to this is that it's this identification of, we can't just provide respite, but we need to really focus on the satisfaction with respite time use. So this is on the right side of the theoretical model here. And so this is identifying another outcome that is associated with not just well-being, but how people are using their respite time use. Is it regular? Is it consistent? But also, what are the activities that they're doing? Not just for the sake that some activities are more beneficial than others, but that they are fitting that individual's needs and desires. Next slide, please. So the app that we have created has three different components. There's the information and education side, and this is just defining what is respite. So we find that a lot of caregivers don't even really know what respite is. And then I'll skip over to sort of the third component, which is resources and referral of how do I get more respite. So this is more the education component and the referral, resources and referral components. And we, again, are not just focusing on connecting caregivers with formal respite services, but we also are providing them resources and referral, or primarily resources about how to have a family meeting or how to talk to neighbors, so that maybe you can get some of those more informal sources of respite rather than just services. And then the crux of the app itself is this virtual coaching about how do I use my respite, how do I plan my respite. This is all framed around a calendar, any digital calendar that you would see through Outlook, but it really has them mark off blocks of time where they're going to have an intentional break, and then it walks them through how to plan their activities, and then they have a weekly review saying, did you do this activity? And based on that, they get some feedback loops, and there's a dashboard that tracks their progress of, are they doing the types of activities and getting the most out of the goal setting and goal review in terms of their respite time use. Next link, or next slide. So at this point right now, we have just finished developing the app, and we are, as we speak, launching into the pilot test. And the pilot test is to test the feasibility of the online delivery, because we know not everybody likes online, but we also know that we're somewhat obligated to do this from a cost benefit perspective. And so we're doing feasibility and initial efficacy trials. It is with, it will use a randomized controlled trial. It is a 16-week intervention where we follow caregivers for about 4 months, looking at how they're spending their respite time. And the particular design that we are doing right now is limited to 150 dementia caregivers in our community. And we have designed TLC that it could serve any type of caregiver. However, our funding is tied to National Institutes on Aging, where there really was a big push for dementia caregivers. And so our actual research design is focused on the 150 dementia caregivers at this time. We think, though, that this product could be used in a much wider set of caregivers once initial efficacy is found. So the other thing that I haven't mentioned much, but the way that we designed both the development of this app as well as our pilot testing, our randomized controlled trial, has been all community engaged practices. And I think that this links really closely to what Kim was bringing up before, is that so much of this research that we do is not based on diverse samples. And so we have, in the development of the app, we engaged with, it was about a 15-person community advisory board that we selected to represent diverse community groups, providers in the community, former and current caregivers, and we had them give us feedback along with our design and our app development team all the way along. So the imagery, the language that we used, even just some of the concepts that we had about this goal setting and the time use have been influenced by our community engaged, or our community advisory board. We also are, as we get into the clinical trial, we are governed very much by sort of the traditional research perspective, but we are using, instead of going to a clinical site or partner to recruit, we have, for example, hired and trained community health workers representing each diverse community group that have well connections, and they're leaders within these diverse community groups to do a lot of our recruitment. And so we're trying this all out now, but it's with an eye that we can hopefully get, one, a product that serves the largest and widest range of population possible, as well as most diverse sample as we can, particularly in this dementia caregiving sample that we are going to use in this particular study. So next slide. So I don't really have findings of the associated with the efficacy of this analysis or with this pilot. No, with the app that we have created. I don't have it because we are just now launching into the efficacy and feasibility trials. And as we did this, COVID hit. And this was a really interesting thing because we have spent a year and a half, almost 2 years, developing the app. And it was all about talk to your neighbors about how you can get more respite, use these formal services, where a lot of these things became inaccessible, or at least not as accessible as they once were. We did not have the ability and or the funds to go through and change our model at all, but because of COVID, we just had to say, we know that caregivers are more isolated. They're perhaps not able to connect with as many forms of respite as they were in the past. And so we have now, over the past few months, created a few new information modules about what is respite in the time of COVID, when maybe you're not able to leave the house, or maybe somebody else isn't able to come in and provide respite, but what are some creative opportunities for respite? And how do we redefine respite as maybe it's not a few hour break that somebody gets, but maybe it's a 15-minute mindfulness meditation. So we've created some additional resources for caregivers that are a little bit more isolated and don't have access to informal or formal respite. So with that, final slide. With that, it's that's kind of where we are. This is the Time for Living and Caring study, and we look forward to presenting the results of the feasibility test in, it'll be a couple of years when we finish the trial of the full 150 sample. But we also have planned to demo this app with providers throughout the United States and show them and get more the provider perspective as part of our feasibility. So we'll also be doing that, hopefully with the assistance of Arch, to demo this app and get the feedback in that level. So at the end of the study, we hope that we have an app that is well tested. It is evidence-based in how it's been created. And we hope that with this feasibility data from providers as well as caregivers themselves, that we have a product that is closer to dissemination, because it would be sort of an add-on service or benefit for to be used by respite service providers and caregivers themselves that will not cost a lot of money to administer. So thank you for letting us share with you what we have been doing in terms of the Time for Living and Caring study.
And thank you, Dr. Utz. I was looking at some of the comments, and we don't have time to go over all of them, but I can say one person said, love it, love it, love it. And I say, yeah, it was excellent information. There are people who want the app, And so just bear that in mind.
Yes, and I want to respond to that really quickly, because this study is, because this app was developed as part of a grant, and we're just now launching into the study of it, I cannot share the app itself until we're at the end of the grant. However, many of you who are providers, or any of you that are affiliated with ARCH, we will include you in the sort of provider sample, and we'll reach back out to you in the next year or so, where we can demo it and get your feedback at that level. So stay tuned. Research takes time, and I can't share it with you completely yet.
I think most of us understand the time. Thank you again, Dr. Utz. I'd like to now turn the mic over to Dr. Joseph Gaugler at the University of Minnesota. So Dr. Gaugler, it's all yours, and you'll be sharing your own slides.
Great, it says host disabled participant screen sharing. Can someone make me a co-host, please?
You may go ahead, Dr. Gaugler.
Great. Thank you. Okay, well, thank you everyone so much for having me here today. I really appreciate it. And what I'm going to do today is, I think you'll see that the talk and the presentation I'm giving here has some nice parallels and overlap, and maybe builds a bit on Dr. Utz's talk on respite and some of her very intriguing work in this area. Really what I wanted to do here today was to reflect a little bit on the 2015 report, a research agenda for respite care that ARCH had distributed in 2015. And you know, it's a very impressive document. I really commend all of the people that worked on it, particularly Dr. Kirk, Jill Kagan, and the many other individuals who contributed this really important report. And I reflected on it really in the context of these many other initiatives that have been going on. Now, admittedly, and to be frank, I am very much focused in dementia care and dementia care innovation. I mean, that's my area of interest. So I'm really going to be approaching it from that lens. Please do take that with a grain of salt when I talk about this, and how I see this report as, in a way, an important precursor and very much aligned with many of the major recommendations that have been coming out from major national summits in how we can improve dementia care, and how it relates to respite care. And also, too, in thinking about how does the 2015 report, how do some of these other taking stock exercises of how we're doing research in this space influence future questions and maybe future areas we should be addressing. So that's really how I'm approaching this particular presentation. Throughout, I'll be interspersing some of our work that we've been doing, as you'll see. But again, I wanted to align it with this report and talk about how I see this really mapping the future for how we can address subsequent and important questions as it relates to respite. So the first thing that struck me when I was reading the report was how the report framed the challenge of researching respite, and particularly who benefits. And I've also noticed in some of the chats that this has come up as well. And admittedly, the report focused on the family caregiver as the principal beneficiary of respite. However, it did also allude to the fact that, of course, there are many other potential beneficiaries of those who might utilize and receive respite. And right away, what struck me was, again, vis-a-vis the ARCH Respite Network report, kind of a nuanced view of how we should really be, the level of analysis we should be adopting when we're actually evaluating respite. Now, evaluating respite in and of itself, I think, is a complicated, nuanced thing, as you'll see later. But oftentimes in research, we often, because of how we're trained methodologically, really for ease of interpretation and analysis, we often focus on individual beneficiaries of given interventions, for example, respite. So when we examine the effects or we evaluate respite, oftentimes the key respondent is an individual caregiver. For example, the quote unquote primary caregiver. Again, primarily in the area discipline of gerontology and aging. Perhaps it's different in other areas. But as I think many of you probably know, particularly those of you that are working in the field, you know that in fact, often care for older persons occurs within a network. It can be a network of multiple unpaid individuals, family members, maybe friends and others. Could also occur amongst professional care providers. I don't think the methodology has caught up yet to really effectively analyze what is the effect of respite care on care networks. Okay, so why is this important? You know, more often than not, the outcomes that are examined and considered in respite are the traditional, kind of the traditional actors: caregiver stress, caregiver burden, caregiver depression, maybe care recipient use of services such as residential long-term care. But take a step back for a second, and you know that poll question that was disseminated related to the policy context of all this. To me, the strongest argument for respite care, for other community-based long-term care services, really isn't, you know, do we have enough randomized controlled trials of respite, or can we say with any degree of conclusiveness, is respite efficacious or not, or even effective or not? To me, the much more pressing issue is this: there simply are not going to be enough unpaid individuals around to care for older persons with significant health needs in the upcoming decades. I don't know if all of you are familiar with that very famous, I think very highly cited AARP graphic, which is basically, I think they call it the care to something ratio, but essentially it's a ratio of the number of unpaid individuals, most prominently family members, available to care for older persons with significant care needs. Right now, the ratio is roughly 7 to 1, 8 to 1. Within the next 20 to 30 years, that number is going to drop to around 4 to 1. That's because of a number of different socio-demographic factors, which we don't have to get into here. But nonetheless, quite frankly, from a public health standpoint, we can no longer continue to rely so heavily on unpaid individuals providing the bulk of long-term care services. Simply, there aren't going to be enough of them to rely upon. I call this the family care gap. How are we going to offset that family care gap? I mean, clearly, from a policymaking standpoint, respite has to be a solution, or some type of community-based long-term service and support system has to be a solution. Now, again, whether how that is financed from either the federal or state to state level, and then how that's evaluated vis-a-vis research and in terms of can it offset the family care gap, I think are very much open-ended questions. Work like Dr. Utz is doing related to time use are pretty critical in this regard, because time, caregiving time in and of itself, I think is a key public health outcome. If you have an intervention or service that actually can reduce family caregiving time, that to me is a really important outcome, but it's not an outcome we've considered enough or consistently in the research literature. So that kind of goes along with this idea of the challenge of researching respite. I think another issue that emerged out of the report for me when I was reading it, and it kind of reflected on some of the work and research we've done, was actually trying to define respite. This is the definition that's provided in the report itself, but there actually was also an appended definition too, which was much longer. It was long enough I couldn't fit it on my slide. And it makes a lot of sense in that respite can encompass a lot of different things. It encompasses different stakeholders in terms of who utilizes and benefits from respite, who delivers respite, how it's delivered, where it's delivered, intensity, etc. So there are many, many factors when considering kind of the quote unquote intervention of respite itself. That being said, understanding that complexity is important, but the flip side of that is what really is respite? And because it has a fairly broad definition, and it certainly even has a broad definition in the research literature, it makes it very, very difficult to pinpoint and categorize what is a respite intervention versus what is not a respite intervention. And more importantly, when we actually combine multiple studies of respite, are we actually looking and comparing the same things when we make conclusions as to whether respite is actually efficacious or not? And that leads me to a paper we published a few years ago where we actually looked at what are called systematic reviews or meta-analyses, in this case of dementia caregiver interventions. Meta-analyses are basically large-scale attempts to synthesize and pool the effects of multiple studies in one big meta-analysis or study. The thought being that by pooling a number of different interventions together, we can get a better sense of, do these interventions actually work across, large number of people, of studies conducted in different places over different times, et cetera. However, when we actually looked at the different types of dementia care interventions, and respite was one of the types we examined, we found a very concerning, if not shocking, level of inconsistency in how respite was categorized across these reviews. This is just a snippet from the paper that I wanted to share with you. And essentially, what we're saying in a nutshell here is across different reviews that were conducted across a relatively similar time frame, many studies that were considered respite in one review weren't considered respite in another, or were included in one review, were not included in another. And so why is this important? Why does this matter? Again, when we get back to this whole context and issue of the policy context, how can we make the case to policymakers? You can make a very strong argument that if we actually look at the research literature, we look at some of these systematic reviews, for example, the systematic reviews that were updated in this most recent bibliography that Arch distributed, I'm willing to bet that in fact, how respite is defined, and the studies that are kind of grouped into this category of respite remain very inconsistent across these reviews. So it really, really muddies the waters in terms of us trying to understand, does respite work or not? Part of it is the great challenge we have of trying to pinpoint and define what really is a broad, complex, rich service approach that encompasses likely very different things. For example, respite can include adult day services, but include a lot of other different types of programs too. And you can make the case when you look within adult day programs, it is very hard to say one adult day program is doing the exact same thing as the other, because quite frankly, they're not. So again, understanding and trying to group and synthesize the effects of these different programs across the literature is very, very difficult. And it's a nuance and complexity that I don't think we as researchers actually appreciate. And certainly I would argue policymakers and others don't either. What's one way around this? One way is to improve how we actually report these types of interventions, whether it's respite or other types of dementia care interventions too. I'm not going to, I had a link here to a table. I'm not going to show you that now for the purposes of time, but there are ways, they're basically called classification strategies, classification taxonomies that really allow for better reporting of what the interventions are. You know what, I guess I convinced myself I'm going to show you the table here. So hopefully this shows up. Hopefully I'm not being too fancy. This is an example of a way to use a taxonomy to better view or to better report on interventions. And this is done in the concept of what's called a protocol paper. Protocol papers are fairly rare in dementia care, but they're becoming more popular. And why they're important is they don't report on effects or results, but what they do is they more or less outline, these are the procedures we implemented. And they're done with a degree of detail where you could give someone a protocol paper and they could, with a fair degree of confidence, replicate the intervention that you are evaluating. But you can see here how important it is to really define what it is you're doing as an intervention across these various delivery characteristics. Mode, method of contact between the interventionist, in this case a respite provider, and a participant. The materials, what is used to actually deliver the intervention. Where does it take place? How often? Duration and intensity. Are there other degrees of detail in terms of the interaction between the interventionist and participant? And the list goes on and on here. So again, I mean, this is one way to advance the research to better understand what are we talking about when we're discussing respite in our studies, okay? All right, whoops, sorry. Let's go right back to where I was. Okay, another, I think, really interesting point in the report were outcome measures. And one of the areas I think we as researchers in dementia care, but probably across the continuum of respite care should consider, and I would argue individual, the developmental disabilities literature and probably other areas of literature perhaps have done this better than dementia care, which has still more or less immersed itself in deficit-oriented outcomes, because that is in keeping with the biomedical perspective, is, again, why do we only focus on caregiving stress? Why do we only focus on potentially negative health outcomes on the part of older participants using respite, et cetera? There are likely a number of strength-based measures that better capture the benefits of respite. And unfortunately, in research, we are not considering them as consistently as we should. And I've given you some examples here. For example, resilience, successful aging domains. One really, really interesting approach is called goal attainment scaling. This is a very person-centered approach, and I wanted to mention this because I noticed a chat, someone had made a comment about the need to really incorporate more person-centered outcomes. Goal attainment scaling is at its core really a person-centered outcome. It was originally developed for educational settings and over time has developed through psychology and now has reached the healthcare settings because there is an increased interest in what are called patient-centered outcome research instruments. I like the term better, person-centered outcome research measures. And so what goal attainment scaling really is at its core, it's a little more complex than this, but to make it simple, is essentially identifying goals of a user of respite, whether it's a caregiver, whether it's a person who's receiving respite, et cetera, and identifying, okay, what are the goals you would like to achieve or accomplish after using respite? Let's say over a 3-month period, 6-month period, et cetera. Then returning to those goals in 3 and 6 months and asking the respondent, has the respite program exceeded your expectations? Has it met your goals? Has it fallen short of your goals? The reason why this is so important is oftentimes the measures we use in research, they do not capture the context, the reality, the lived experience of respite users. And I hear this over and over again from providers. I hear it from family members where you might administer, say, a caregiver stress measure to them every 3 months, 6 months, every year, whatever, and nothing changes in your analysis. But then when you actually talk to family members, you hear things like, man, I wish I had known about this sooner. Or, this was really helpful. It was a lifesaver. You hear those contexts and those quotes over and over again. And I think our challenge as researchers is how can we capture what clearly are positive things happening on the ground into our research designs and our research outcome approaches. Goal attainment scaling is but one example, and there are many others in this list here. One really interesting initiative that's happening, it's an international initiative, it's called LinkAD. I'm part of this, and it's basically a way to totally reframe how we measure well-being, in this case, the context of Alzheimer's disease. There's more and more work that's going to be emerging from this over the next few years, and I'm very excited to see how it might impact the field, particularly how it might even impact respite and respite provision. We've talked about this a little bit, but one thing I think is also important in the context of respite for us to think about is, again, and I think much of the predominating focus of maybe the report, but also our overall conversation related to respite is it always seems to come down to, well, let's make the case of whether respite works, or is respite efficacious, et cetera. Now, I've talked a little bit about how complex that actually is to determine. I would argue, even though the gold standard is the randomized controlled trial, and we can argue whether that's appropriate or relevant anymore, I think it would be very, very hard now to conduct a randomized controlled trial of respite services, just because of their ubiquity, it's going to be very hard to randomly assign someone to receive respite or not in this context. However, the way I also really like to think of respite or other community-based long-term service and support programs is as a context, as a foundation, a location to disseminate and implement evidence-based innovations in long-term care to then see if they actually are efficacious. Can they actually boost or enhance the respite care program as delivered, if that makes sense? So one example I wanted to share with you is a study we're doing now. We call it the ADS Plus study. It's a 5-year study that's funded by the National Institute on Aging. Myself and my colleague, I'm sorry about the slide here, Dr. Laura Gitlin, she's actually at Drexel University now. I'm now in the School of Public Health at the University of Minnesota. But we actually came together. This is building off of a project Dr. Gitlin had done in the mid-2000s called ADS Plus. And really what ADS Plus is it augments adult day services with systematic evidence-based caregiver support, education, and skills building. The goal being is that we believe this will enhance well-being, not just for caregivers who receive this augmented, again, ADS plus service, but also for people with dementia who receive care from these individuals. It includes close to 50 adult day programs throughout the US. And what we are doing is when we deliver ADS plus, these are the various elements of the intervention itself. Time doesn't allow me to go exactly into the intervention, but it's essentially based on a number of evidence-based dementia care interventions that Dr. Gitlin has evaluated and refined over the years. And now what we're doing is taking it and implementing it within adult day services, where adult day service staff deliver the intervention to family caregivers and can do so remotely. These are the main objectives of the program. We're following people over 12 months. We're looking at these various outcomes as well as cost effectiveness. And here is essentially the design. I mean, we're not going to go into this in depth, but we're trying to collect a lot of information, both empirical over the 12-month period, but also a lot of process evaluation. I mean, how was the intervention delivered? How was it received? You heard Dr. Utz talk a little bit about treatment fidelity. It's somewhat associated with really examining not just the delivery of the intervention and whether it adhered to what we expected, but also the process of delivering it. How did adult day staff react and respond to actually delivering this intervention? Now you can imagine, because of COVID, this has wreaked havoc a little bit on our original design, but at the same time, it's giving us an opportunity to also examine and emphasize the importance of adult day programs in the context of a pandemic such as COVID. Okay, so that's really the ADS Plus project, an example of using respite services again as a platform for disseminating and implementing an evidence-based intervention. I wanted to conclude on a couple of slides here. There are some really powerful quotes in this op-ed that I actually wrote with the ADS Plus team that we actually we had published at the end of August in the Star Tribune here in Minneapolis. And both of these quotes are from participants in the Adult Day Service Plus program. It's still not easy. Depression, helplessness, and frankly, plain old boredom make it mentally taxing. I have to explain to my mom several times a day that we're living through a pandemic right now, what coronavirus is, why we can't go. To the adult day program, which she calls school in a good way. The mind of the caregiver is substantially passively stressed. The daily mental torture is real. This is from a family caregiver in California who, again, is dealing with the day-to-day care responsibilities after her mother's adult day program had closed. This was from a 30-year development director of another program in her study in Minnesota that had been open for over 50 years. And it ended up closing for good because of COVID. And really what she said is, you've heard that my program is closing for good. Needless to say, this leaves a large hole in this important service. I'm not sure how many champions are out there, but if there was a time, it is now. This isolation has been a disaster for older people. So really what the ADS Plus program really motivated us to do, and we heard from program providers, we heard from caregivers routinely after COVID-19 hit about how important these programs really are to people, to older persons living with dementia, to family caregivers. And our goal is to merge this policy imperative, this crisis really that's happening for family members, adult day service providers, or all respite providers in this case, with the need to align our research to meet the challenges of this crisis. And we believe projects like the ADS Plus study that, again, adopt a dissemination implementation lens in its work, adopt the use of multiple methods, including really robust qualitative methods alongside empirical methods, can help better address the experience of using respite, but then also really how respite can be advanced as really a key major option to offset what I talked about earlier, which is really the family care gap. I'm going to stop there due to time. I provide a number of references in my slides, and forgive me, Jill and others, I don't recall if the slides have been distributed to everybody. If you do want these slides and they're not, please feel free to email me, or you can see our new Twitter account, UMNCHAI. That's our new Center for Healthy and Aging at the University of Minnesota. Please do follow us there as well. Thank you for your time. Appreciate it.
Thank you so much, Dr. Gaugler. The slides will be available. So that answers that question. And not that I don't have other things to lose sleep over, the whole idea of the care gap, I've worried about that for years. Thank you for bringing it to our attention once again. Just excellent information. So I want to thank you once more. Let's now transition to Dr. Sarah Sobotka with the University of Chicago. So Dr. Sobotka, I'm handing the reins to you now. Thanks.
Thank you. And thank you for the opportunity to present really with colleagues who are doing such important and really very thought-provoking work. I have really enjoyed listening to the presentation. So I'm going to focus on respite care for children. I don't have any disclosures, but here's funding, my funding for my work in general. And my objectives for this talk is that we'll talk about the pediatric population that typically qualifies for respite care. I'll talk about the distinct opportunities and challenges for pediatric care. And finally, the current barriers that I've found in my work or and in other works, and planning for next steps. So first, when we think about children who typically qualify for respite care, we're thinking about children with medical complexity. And the subpopulation that I most intimately study are children who have home mechanical ventilation. Generally, children have home mechanical ventilation because they have a primary respiratory or neurologic cause. About half of these children are survivors of prematurity, but certainly other diagnoses require ventilation, for example, hypoventilation syndrome, cervical spinal cord injury, and spinal muscular atrophy, to name a few. So just to take a pause, and I've learned so much from the dialogue around respite care, but to think about what's unique to pediatrics. And I think that thinking about that requires us to name a couple of assumptions that we have, presumptions that we have about really the relationship between a child and a parent, because that paints a picture for what the barriers are. So we as a society and individuals as parents presume that the parent is often the primary caregiver to a child, and sometimes there are ideas about the intensity of that. And so typical newborns, we think, are entirely dependent upon their parents. And likewise, we have some assumptions about what the presence of young children does and the impact they have on their children, or on their parents. So we know that the presence of young children may limit time away. Perhaps we expect, whether implicitly or explicitly, that changes employment opportunity or changes sibling relationships, etc. And I mention all this not to share any judgment on these presumptions, but just to remind us that this sets the stage for some of the barriers, not only on a societal implication, but really even among the caregivers to accepting and pursuing and not having guilt regarding respite care. I also want to call out that for children with medical complexity, we're not talking just about caregiving, but really complicated skilled caregiving that incorporates medical skills. And so a lot of children with the medical complexity they have, adults with that same level of medical complexity, a ventilator, a feeding tube, needing for constant suctioning, needing for 24 hours a day of an awake caregiver, an adult might be more likely to live within a nursing facility. So we're talking about a high level of skill. So for the pediatric population, and this is an outstanding paper, and actually Dr. Whitmore put the link, I noticed, in the chat earlier. So respite care in the pediatric population, we know it can be unrelenting, constant, and stressful. It can be respite care, however, can be beneficial for the marital relationships and siblings. But the societal expectation that you care for your child full time can be perceived both by a parent or by others as a parental failure. And I think that guilt should be understood as something that we need to work through. So respite care for children with medical complexity can be given a few ways, either through additional hours of home nursing care in the family home, or at times separated into a facility. And I would be really remiss to not mention the most outstanding respite care facility in the Chicagoland region, where I received a lot of my initial exposures to both children with medical complexity and centers of excellence for respite and transitional care. So a little shout out to them. We've partnered together for research really around their transitional care program when kids are first going home from the hospital with medical needs, but they also have an outstanding respite care program. So let's talk about the barriers to respite care that we understand for children with medical technology dependence. And I'm going to present some initial findings and some final findings from research that I'm doing with 3 different informant groups: care coordinators, parents, and home care nurses, which touches upon one of the key areas named by the Respite Research panel, that we want to be really using the family caregiver as the portal of entry to research individual, family, and societal outcomes. So care coordinators within the state of Illinois, the State of Illinois Care Coordination Program is for children with medical complexity. The home care program is for children who have medical fragility and required skilled nursing care. And because of waiver programs, really all children throughout the state who have a ventilator need and home nursing are in some way connected to this program. So it's a nice representative sample throughout the state. And this paper I'll share results of. This was with my colleague and Emma Lynch, who's also in this group, and we looked into outcomes in respite care from 2 sources. It's a mixed method study. The first is the National Survey of Children with Special Healthcare Needs, and then respite themes that emerged from my structured interviews with care coordinators. So the National Survey of Children with Special Healthcare Needs is a nationally representative sample across, it's cross-sectional but repeated over time. And we in this database, and this was not a perfect measure, but we tried to define kids with medical technology dependency by looking at their questions related to home health and DME, and then having a chronic condition that would likely also require nursing in the home. They defined respite when interviewing family caregivers as care for the child so the family can have a break from ongoing care. Respite can be thought of as childcare or babysitting by someone trained to meet any special needs the child may have. And so there was a question about if the family member had a respite need, and about half said that they did. Of those who had a respite care need, about half did not receive all the needed care, and of those who did not receive all of their needed care, about half, or actually more than half, 60% did not receive any respite care at all. So I'm not going to go too much into the demographics of this really, really small cohort within the national survey, but I do want to mention that they did ask a nice question about the reasons why kids would not receive respite care. And interestingly, the most common response was other, which is the most beautiful illustration of why qualitative methods are really important, because this was clearly not, the choices were not all correct here. And so I'll flip over now to the qualitative results of the study of care coordinator interviews. I interviewed care coordinators throughout the state of Illinois who'd been working at least a year in the home care program, and we had conversations which covered a number of topics, but respite care is one of them, and a little bit of our methods. And so 4 major themes emerged. I'm going to go through them a little bit quickly, just being sensitive to time. But the first is that, care coordinators really viewed respite care as an essential service for families. They thought that it was this quote is, I tell parents to use it. I think it's important for you as a couple to reconnect. I think respite is really important for the parent to take a break. They also recognized that for families, it was often underutilized. Sometimes it was explicit. Yes, I have families, but they aren't able to use respite because they don't have their baseline nursing needs met. Other care coordinators simply just didn't really have examples, which I think illustrates that it wasn't being used. When care coordinators described family experiences with respite care, they painted these really very vibrant pictures of families using respite care in order to travel back to their country of origin, with the second quote of a mom who goes back to Jamaica every year, and that sometimes families would want to take a vacation or would need to take a vacation without the medically fragile child, and that would be a helpful thing. Certainly, we've been thinking about respite care in the context of being a rejuvenating break time, but in this data set, respite care is also something families use to tap into for essential needs. So to travel away from for a family funeral, if a parent is in the hospital, if they, even something, I think this is an important illustration too for medically complicated children. If you need to do something in the home that they live, that it puts them at risk, paint the house, they need care elsewhere for a period of time. So respite in this way, at least with the conversations that I had, is not always a period of rejuvenation. Sometimes it's a really essential need. a major theme was both center-based and home-based respite care. There were barriers because of a lack of providers. So families were not able to have 24/7 respite care during in their home because there weren't enough home nurses, or they weren't able to enter a center because the centers did not have beds. And remembering that this is a very complicated population and there are limited centers, if there even are centers in the region. I also noted a couple of very clear, more than a couple, but a theme around respite-related readmission. So sometimes when families don't have that emergent nursing support, they need to be readmitted to the hospital. So the second quote is so illustrative. I have a family who had a mice infestation in their apartment. The nurses weren't going to work there. Nursing stopped. Mom has 3 other kids. So eventually the child was hospitalized because it was just too much. So conceptually, and this is also touches upon another paper I wrote specifically around readmissions. But when families do not have access to emergency or rejuvenating respite care, they for their child may have no other choice than for that child to get readmitted to the hospital, either because it's an active decision or because the child just gets sick because of the lack of consistent skilled caregiving. So in conclusion, a lack of respite providers and centers makes access to respite care often impossible. The shortage of home health providers block intermittent reprieve for families. And the lack of respite provision results in otherwise avoidable readmissions. Okay, so the next 2 studies I'm going to talk about are ongoing. I'm about halfway done with recruitment for both. So I'm doing a study with parents of children with HMV. Their longitudinal study focused on a number of aspects around initial community engagement and sort of initial transition from home. And I also have a developmental testing component where I'm looking at developmental outcomes as well. But certainly respite care is something that we talk about at great length. This is my population so far. I have a next one scheduled for next week, but I have 12 families enrolled with really from very diverse background, which reflects the population in the Chicagoland area. So first, what's emerging from these conversations that there are families that just lack knowledge about respite. And I'll say that sometimes I'm surprised that families who are otherwise very savvy about services or the medical condition about their child or just in general, very educated families that are able to self-advocate still don't quite know what respite care is or don't know how to use it. Certainly families, and this is the same from the care coordinator survey, are identifying that their baseline nursing need is not met, so they're not able to tap into respite. So for example, a family with a child on a ventilator may qualify for 16 hours a day of home care nursing, but additional hours over the course of the year of respite care. But if their 16 hours of home nursing are not consistently filled, being able to tap into the respite hours to be able to have extended time for family members to do other things just isn't happening. And then there's this really clear theme about, and this taps back into what I was talking about at the beginning with parental guilt and sort of the presumption about the role of a parent, that they just can't imagine leaving their child. And I would say that because these are, it's a cohort of incident cases, so kids who newly are home with a ventilator, there also tend to be a lot younger children and younger infants, and that's reflected in a lot of what parents are saying, like, I don't want to dump her off somewhere, it's not like a kennel, I just want my child to be home, I can't even fathom leaving them, that would hate myself in a way. Now, however, some of those same families still identified that there would be examples for potential future utilization, or they could imagine why those the other families might tap into these services. So I really do want to take care of respite care, maybe in the future. And then almost its own theme around Disneyland. Lots of families talked about that Disneyland with an older sibling would absolutely be a reason they would consider respite care where previously they wouldn't. I'm going to briefly talk about a home care nursing study, the third kind of group that I've been doing interviews with. Again, about halfway through recruitment here, and I'm interviewing nurses who have at least some experience working in the home with children. 12, maybe I've gotten a 13th now. I'm trying to lose track. Very similar themes here regarding the nurses recognizing that respite care is important. I think parents need to get away. even if it's just for a weekend, and that helps them also build confidence in the home care team if they're able to step away. They also recognize the importance of center-based respite care, which is really nice to see. Some home care nurses talked about their experience with respite care, that they were part of a respite care team that provided 24-hour support to a family so they could leave the family home. They also have had experiences with kids going on vacation, etc. So quickly pivoting to next steps, I think it's important that for pediatric respite care, we really recognize the overall barriers to respite care, which really are similar to barriers for care in the community in general. Baseline home nursing support for children with medical complexity is drastically underavailable. And so until we fix baseline home support, we're a long way from kind of supporting this in-home respite need. And what was so interesting, and I was thinking about with the last talk, is that when there are these sort of fuzzy lines of what is regular care and what is the break that's needed, I think that adds to the complexity here. And then, you know, bringing respite care to the forefront of dialogues around children with medical complexity. I mean, I remember when Emma and I were doing this study using the National Survey of Special Healthcare Needs, we discovered that the respite questions were removed from subsequent surveys. So really thinking about how baseline nursing support and additional support for intermittent breaks are separate but related and essential for children with medical complexity. So I'd like to acknowledge my mentors and my research coordinator, Emma, who's again on the call, and look forward to the dialogue. Thank you.